Mike, I'm checking in. Can you hear me okay? All right, thank you. Well, I'm thrilled to be here today. I'm so excited to be at this conference. This is my first time at this conference, and so I'm very honored to speak with you today. All right, so my talk is Engaging Youth and Families in Mental Health Services. I'm going to give you kind of a research summary and talk about applications of science into practice. Just some acknowledgments and disclosures, some of my funding, including PracticeWise, which is a behavioral health consulting company that builds resources for mental health providers. I want to extend my gratitude to a team of more than 126 people who have been working on some of the research studies that I'm going to share with you today. These range from undergraduate students to graduate students, postdoctoral fellows, and does not include our community partners, but I am grateful to them, and I'll tell you about them as I go along. I have to acknowledge my longtime collaborator of more than 20 years. This is Dr. Bruce Torpeda, who's a professor of psychology at UCLA, one of the world's foremost experts in children's mental health services. We've been studying treatment engagement for decades, and this is not a picture of us when we started out, but this is our why. Like why we started, we were really working on improving mental health services and talking to community mental health professionals to understand what were the challenges in using evidence-based treatments in their work. And time and again, one of the most important things that they identified as a challenge was treatment engagement, that it was hard to be effective in delivering services when children and families had trouble attending therapy or trouble trying out skills. They had other things, other competing demands. And so we set out to understand, what does the field know about treatment engagement? How do mental health providers think about treatment engagement? How do families think about treatment engagement? And I'm going to share some of those ideas and inspirations with you today. So my aspirations and learning objectives, I hope that the things that we talk about today, I can expand your thinking about treatment engagement, and that you will appreciate even more so than you already do, because I know, preach and choir, I know that you will appreciate the complexity of making decisions about treatment engagement, and that you will feel inspired to act in ways to engage children and families maybe a little bit differently in services. But first, I'm going to talk about a bridge, and John Comer already did. But this is the world's longest bridge. It's 102 miles. It is in China, and it was built in around 2011. It was engineered to traverse many different kind of geographies over water, over land, over water of different depths. It was built to carry heavy railways, high-speed railways, and also to withstand typhoons and earthquakes. Pretty amazing. When we talk about the bridge between science and practice, academic researchers often think that we are building this bridge. Present company excluded, for sure. But we often think that we are building this bridge. But I want to tell you about another bridge. And this is London Bridge, built in 1820, designed for pedestrian traffic and maybe some horse and buggy. And in the mid-1950s, when the population grew and automobiles began crossing London Bridge, it began deteriorating. And to me, this is the bridge that we are building with our interventions in academic research. And the reason is because we are not really testing, by and large, most of our interventions under the most taxing conditions that you, as mental health providers, experience in your everyday work. Low treatment engagement, I can already tell my slides are a little bit off with the formatting, so bear with me, I did not make the font this small, but low treatment engagement is a ubiquitous and taxing condition. I'm going to tell you some statistics about treatment engagement. I'm going to even put on my glasses because I cannot see my own slides very well. Okay, so in clinical practice, about 2/3 of young people in need of services do not even access mental health services. They never enroll in therapy. 50 to 70% of young people who do enroll in therapy discontinue services before they've achieved their treatment goals. On average, the modal number of treatment sessions is actually 2. Most people attend 2 therapy sessions. Those who continue in treatment, according to insurance documents and studies done on insurance claims, the frequency of attendance is about 1 session per month. Okay? It's astounding. And they continue 1 session per month for about 6 months and then tend to discontinue. And as Dr. Polo mentioned as well, those from the most vulnerable backgrounds have even greater disparities. So those from ethno-racially minoritized communities, those with immigrant status, those in rural communities, and so forth. But it's not just in clinical practice. In research studies as well, 30 to 70% of children and families discontinue services from research studies. But low treatment engagement affects more than just the families enrolled in therapy. It affects agencies. So when people discontinue or don't show up in therapy, it consumes staff time and reduces revenue. Therapists, it increases stress and burnout. It reduces their confidence in their services. In fact, there's a study showing that low treatment engagement is one of the top 3 most concerning issues to therapists, most stressful issues to therapists, right alongside treating psychosis and suicidality. Okay? Low treatment engagement, not showing up to sessions, also impacts other children and families. It increases their waitlist times, and people who remain on a waitlist longer are actually less likely to access services when therapy becomes available. So it's a perpetuating cycle of low treatment engagement. Now, what do we know about the research on interventions? So in emotional and behavioral health, so thinking about things like anxiety and depression and all of the clinical problems, there are more than 2,000 randomized controlled trials. In contrast, there are about 70 randomized controlled trials testing interventions for treatment engagement. Now, it's reasonable to assume that, of course, we would not have 2,000 studies on treatment engagement, but treatment engagement has been noted as a problem since the 1950s. Scientists and doctors have been talking about withdrawal from therapy services since the 1950s. We have about 70 studies testing interventions for engagement, and they're not widely disseminated. They're not really well organized either, and they study treatment engagement in various ways. The funding opportunities also for interventions research differs greatly. Now, I made this slide before the events of the past week when there was a lot of funding for emotional and behavioral health interventions. So in contrast, treatment engagement gets very little funding. And at some point, maybe these will both be teardrops, the funding. But in general, academic science has not been able to make treatment engagement yet a priority in terms of its focus. But we can imagine a world where there are significant and collaborative efforts and resources directed toward engagement science as a science and practice to meaningfully reduce treatment disparities and health equities, where mental health providers feel supported and are effective in their roles, and there is a strong public health return on investment. The money we put into science pays off on impact, and that children and families can meaningfully participate and benefit from effective services. We can imagine a world where, even today, where the margins feel like they're getting wider and more people than ever are stressed and feeling excluded, this problem is only going to get worse. But we can imagine a world where we come together and really address issues related to treatment engagement. And it's all about children and families. It's about helping them feel connected and benefit from therapy. But talking about treatment engagement can feel very vulnerable. And so I'm going to do one step toward normalizing talking about low treatment engagement and engagement failures. And I have many stories, some of which make me cringe, and I don't want to share them in a very public setting, but I will tell you a story because I've heard that what happens in Miami stays in Miami, except when it's memorialized on video. So I will tell you a story of my early clinical days when I was very excited to work with children and families. And I was working at an outpatient clinic, and a mom came in with her 7-year-old daughter who was having issues with compliance and disruptive behavior at school. And the mom was showing some signs of depression. And Andrea, your example earlier, it could have been me. I wish I had heard the things you said when I was much younger. So I was so excited to tell this mom about, evidence-based treatments and how we could work with her and address, do some special time and help her learn some different ways of giving commands, and told her all the spiel about how this might help address the child's disruptive behavior problems. And she left that day. And I was very excited for her to come back. And a few days later, I received a phone call, not from the mom, but from a pediatrician who told me that my intention of sharing, this information with this mom had actually had the impact of blaming this mom, of making her feel blamed when the school was already making her feel blamed, and made her feel that I did not understand her set of circumstances. And so I took this information to heart, and I figured the next time I see this mom, I will repair this situation. And as you can imagine, this mom never came back to therapy. And so I missed that opportunity. I see people nodding, and maybe in sympathy or a similar experience. And not only was it terrible in that one circumstance that this was really my mistake and a missed opportunity to engage this mom in therapy at the time that she needed it, but I was likely her bad experience in therapy that she took with her going forward, that made her pause when she thought about reaching out for help again. So I want to ask you, I know you've been sitting for a while, so this is going to be the time of the talk where you're going to get to move. You're not going to stand up, though. You're just going to move an arm of your choice. And so I wonder who has, with a show of hands, who has ever wondered if a youth or caregiver is engaged in therapy? All right. What about wondered or worried if a caregiver or youth likes you? Yeah, I see a good show of hands. All right. Had a client discontinue therapy? All right, many of you. Had a client complain about you like the way mine did? Okay, some of you, thank you for being brave. All right. Had a client say, I hate you. Okay, I see a few. And call you a whore? Your hand is still raised? An adolescent. All right, I got you. Mine was a 4-year-old who was pretty aggressive in session, was in his 8th timeout, and he was escalating. So he said, I hate you, and you're a whore, doctor. But 4-year-olds are fickle. And by the end of session, we were eating M&Ms, and he gave me a hug on the way out, so it all worked out okay. I hope yours worked out as well. No, it did not, so, okay. And how many of you have experienced your own engagement concerns in healthcare at some point? Yeah, okay. So these treatment engagement applies to all of us in some way, whether in our own experiences as a therapist or in our professional role or maybe in our personal role. And so that will make it extra awkward. If you get up and leave, I will know it's not because the topic isn't relevant. All right. So I'm going to talk about 3 considerations that are essential to treatment engagement: conceptualization, measurement, and interventions. Conceptualization is how do we think about engagement? I'm going to tell you another brief story, and this is much more recent. This is my experience as a clinical supervisor, and I was supervising a trainee who, by all accounts, if you were to meet this trainee, you would say, this person is very engaging. They're warm, they're optimistic, they're encouraging. And this trainee was working with a mom and a teenage boy, and the teenage boy also had kind of some conduct problems at home and at school. And we knew to very early on pay attention to treatment engagement in our supervision. And so I asked the trainee, how are things going with the mom and the son? And the son was very engaged in therapy, participating in session, sharing, private thoughts and things like that, seemed to be trying some things out at home. The mom also attended appointments regularly, was trying some things out at home. And like we should do, we continue to pay attention to treatment engagement over the course of time. And about 8 weeks into therapy, we were checking in about how things were going and talking about treatment engagement. The mom was still showing up very regularly. And my trainee said, though, that mom wasn't really trying out the skills, and she seemed resistant in therapy, in fact, when they talked about different skills. Now, resistance, that term, that's like a huge red flag to me. So I said, we should watch some video. Let me see what's going on that you're interpreting as resistance. And I saw what she was observing. I saw mom asking questions, raising concerns, saying, I don't think this fits our family. And my trainee, again, eager, she was my previous self, she was eager, she was providing a lot of information about why these skills were essential for this family and how it could be helpful to this youth. And when we talked about, what we were observing, and we made a plan for the next session to make some adjustments, but wouldn't you know, the mom called the clinic and she said, I want a different therapist. Okay? So I said to my student, alas, now I have an anecdote for every talk I ever give for the rest of my career. So I'm going to tell you a little bit about how this relates to conceptualization. So first, in our own research and talking to mental health providers and looking at the literature, people tend to think about treatment engagement as very behavioral. Okay? So thinking about people showing up or the things that we can observe. And so why does this matter? Why is this problematic? Because there are things under the surface that are not transparent to us when we're providing mental health services. Private thoughts and feelings that unless we ask, we might not be shown. We also tend to think about engagement as static, that once somebody is engaged, then they're engaged for the rest of therapy. Or once they're not engaged, like the reverse could be true too. Once they're not engaged, there's nothing we can do to engage them. And that limits our interactions with people. We might also consider engagement as trait-like. So this can come on the part of the provider. As I mentioned, by most standards, my trainee would have been viewed as an engaging therapist. She would have. I hear the reverse sometimes too when I gave my example, that using terms like resistant or unmotivated or they don't care, I've heard the gamut of things. It's like as if it's something innate to the person, okay? And that leaves us feeling frustrated and feeling disempowered, like we can't do anything about, to improve somebody's engagement. So I would like to propose that we think about engagement differently, that we actually think about it in a multidimensional way. And I'm going to share a little bit more about this in just a moment. But rather than just behavioral, that we think about engagement from a social perspective and a cognitive perspective and a behavioral perspective. And this will give us a much broader lens of assessing engagement and being able to act to improve engagement. I would encourage you to think about engagement as dynamic. Research actually suggests that engagement changes within the course of a single therapy session, that it improves from start to finish. and that over the course of therapy, like in between sessions, engagement tends to decline a little bit, and that it improves again. So it's kind of like a little bit of a wave. Research also suggests that even the people who appear to have the weakest therapeutic alliance at the outset of therapy tend to improve their engagement over time. So this is really optimistic. This means that if engagement is dynamic and not static, we can do things to improve engagement. And then I'd also encourage us to think about engagement as transactional. It is an interaction between a therapist and a client. The client and caregiver and the system that you're working in, the agency within their community as well. And again, if we think of engagement as transactional, it means that we have more options to improve engagement, okay, and to understand what children and families are going through as they're enrolled in therapy. So we proposed the REACH framework as a way to think about engagement. Now, it's not the be-all and end-all of engagement dimensions, but it might be a helpful mnemonic for you to consider. So the REACH framework represents 5 different ways that people might be engaged or not in therapy. So the first one is the relationship. This is, the therapeutic alliance. It's the extent to which clients believe that, they like their therapist, but also that they believe that the therapist and themselves are working on the same team towards shared goals. This might also involve somebody feeling understood by their therapist. Expectancy has to do with somebody's optimism that therapy will be useful or successful, that they themselves can be successful in therapy. Okay, so this is the hope that people bring. Attendance, of course, is showing up or canceling with notice and things like that, not allowing, trying to limit the interference of competing demands. Clarity has to do with somebody's understanding of the goals of therapy. Like, why am I in therapy? How does this therapy relate to my concerns? Understanding the roles of the different people in therapy. So what is the caregiver's role? What is the therapist responsible for? And so forth. And then homework has to do with practicing things outside of session or following through with treatment recommendations. It also could represent the active part of, participation in therapy as well, okay? So the REACH framework is a way to broaden your conceptualization, broaden the way that you think about treatment. So just a few recommendations as we think about from the conceptualization is remember that engagement challenges are common. Most often, they have nothing to do with whether somebody likes you or not. When we have surveyed children and families, it is very rare that people report not liking a therapist. There might be other interference with the therapeutic relationship, but it's usually not because they don't like somebody. So engagement challenges are common. So about 50% of the time or so, people that you work with are going to have engagement challenges. I would encourage you to heed diction. So if you notice that you've said somebody is not engaged or not motivated or resistant or difficult, pay attention to that because it might be coming across to them as well. And if you work with other people and notice that they use that language too, try to shape more constructive language. And then converse and act as if engagement is multidimensional, dynamic, and transactional. And we'll talk more about acting, what you can do to improve engagement in just a few minutes. So moving on to measurement. How do we measure engagement? Well, we've asked providers, how do you measure engagement? How do you know when somebody is engaged or not? And by and large, they say attendance. They rely on attendance as their primary indicator for whether somebody is engaged or not. And in a survey that we did not have a single provider tell us that they directly asked children or families about their own engagement, which is really interesting. And so I show this picture. I get this image of us doing this covert observation or mind reading, not having explicit conversations, but trying to guess and observe. Because again, engagement challenges feel vulnerable to bring up. Now, I know that there are some agencies that use some sort of engagement survey, and so that is becoming a little bit more pronounced. If you're using an engagement survey in your agency to measure engagement and make decisions about treatment, that's really important. But by and large, our measurement for engagement is not very strong in the field. We also looked at 52 studies that tested engagement interventions. So these should be the best studies to see how do people measure engagement. And we found some surprising things. Well, they weren't really surprising because we know that attendance is a primary indicator. But even in these studies, most of these studies measured attendance and many measured only attendance. They were trying to improve engagement and they operationalized engagement as attendance. Did somebody show up or not? And so here's another image, if you need another image of why that's problematic. This is a truck that has ignored the signals of a low bridge and is now suspended, halfway with its front wheels because the warning signs weren't there. If we rely on attendance as our primary indicator of engagement, we are missing other signs that precede discontinuation or inconsistent attendance. In these studies that are the gold standard of testing engagement interventions, only about a quarter asked youth or caregivers directly about their own engagement. So again, even in these studies, they're making guesses about engagement. And engagement was typically measured once, often after treatment termination, which means it was, again, very late measurement to be useful to the provider during the actual service episode so that the provider could make some adjustments. So in light of this, I should say, when we looked at these studies too, there were not many widely available measures of engagement. You'd be hard-pressed to find something. Most measures of engagement are developed specifically for a study, but they're not widely available. So we developed what we call the My Thoughts About Therapy questionnaire. And it covers the 5 reach dimensions. And there are youth and caregiver versions in English and in Spanish. This measure is freely available if you would like to use it, and it has a scoring program and a user's guide. This is where you can find it. But we developed this measure because we wanted to put something out into the public domain that could measure engagement across different dimensions, all on a single measure. So let me show you. We have been doing our work in Los Angeles and in PD and Santee Wateree, South Carolina. Where's Stephanie? Is Stephanie in? Oh my gosh, the one person I know is not in here. Okay. Stephanie is from PD. We were literally just talking about PD, South Carolina. So we've done a lot of our work in these 2 areas, and we administered this questionnaire to more than 1,800 young people and their caregivers, and a very diverse population in terms of race and ethnicity. And what we found was, in looking at this measure did, in fact, show that there are 5 different engagement dimensions. So it's not just taking our word for it. When we looked at the properties of this measure, it could measure relationship as a distinct entity from expectations, distinct from clarity, and so forth. And these 5 dimensions were consistent across youth age, youth race, region, and caregiver language. Okay, so this seems to be a pretty good measure to use in a diverse population. What's also helpful potentially about this measure is it means that you can measure 5 reach dimensions using a single instrument. If you wanted to measure 5 engagement dimensions before this measure, you would have to find 5 different instruments to use. Okay, so I'm letting you know that you could consider using the MTT questionnaire in your own work if you'd find it helpful. But if you don't want to use it, some recommendations are, first, measure multiple engagement dimensions. It will be helpful in your work. Elicit youth and caregiver perspectives about their own engagement, and measure engagement early and often because engagement is likely to change. All right, so what works to improve engagement? We were so curious to know what works, what does science show? And so we looked at 50 randomized controlled trials, and we read these studies and we coded them for 30 different engagement practices. We found 30 different engagement strategies that were part of effective engagement interventions. But we didn't want to just kind of know what these practices were. We wanted to know, can these engagement practices improve these engagement dimensions? That's really important. If all we see in the literature are things improving attendance, it's less useful than if we know what improves relationship and what improves clarity and so forth. And what we did find is that there is practice problem specificity. So across those 30 interventions, we found that some were useful for many different engagement dimensions, but certain practices were very specific. There's Stephanie. You're good. I'm going to talk about South Carolina in 1 minute again. All right. So as an example, these are really straightforward. If you come to my workshop, I'll tell you more. But just as examples to illustrate, psychoeducation, telling somebody about how the treatment is tied to the problem increases their clarity, their understanding about therapy. Appointment reminders obviously improves attendance, and instilling hope improves expectations that therapy will be useful. So let me tell you the ending of my student's story. And that is, we got the call that the mom wanted to leave my student and have a male therapist. And I said to her, let's think about the way you've been approaching engagement with this family and what we might be able to do differently. I said, of the 5 reach dimensions, where do you think the challenge is? And she said, I think it's clarity. I think that mom doesn't understand that these practices are really going to be useful for her son and these behaviors. And I said, I think from what I've observed that there's something maybe with the relationship, like maybe we don't understand her fully, and expectations as well. That like she doesn't believe. It's not that she doesn't understand. She doesn't believe these practices will be useful to the family. And so with that reframe, we thought about what could we do in this situation when mom is asking to leave. And we made a plan. My student called the mom and asked, would she be willing to meet one more time? Just one more time. And the mom said, yes, but I'm bringing dad. And the two of them showed up to therapy. And my student and I, knowing this, we rehearsed some different strategies. And the primary strategy we used was something we call understanding identities, beliefs, and values. And that is asking people about their personal identities and how they relate to their beliefs about therapy and their values about therapy. And what I didn't tell you is this family was military connected, and they were an African-American family living in South Carolina. And my student was neither of those. My student isn't even a parent. And so in this conversation, my student was like a rock star. She used her innate empathy to facilitate a really difficult conversation about how being military connected, an African American in South Carolina, what that meant to this couple as parents of a black teenager. And she understood why just talking about these practices was not enough and why she was not meeting the expectations they had for what they wanted to get out of therapy. This conversation was so successful that not only did this family remain in therapy until they achieved their treatment goals, Mom brought back her other child to specifically work with this student. Okay? And so I tell you this because now this is a great story for a talk. It was an okay story that probably left you feeling a little icky, but this is a great story about how identifying engagement in a different way gave us more strategies about what to do. All right, so there is guidance about which practices to use for which problems. And so we asked ourselves, how can we leverage this information to help providers help youths and families? And we developed the Reaching Families Engagement System. And based on essentially two design principles. One is that, here's my other beef with academic science, is that we have a tip of the iceberg problem. So bridge, iceberg, we have a tip of the iceberg problem where we have a very vast knowledge base, evidence base, and we use a few things that we know. Okay, so if you open up most treatment manuals for mental health conditions, you'll see a couple, maybe 2 to 4 engagement practices. But I told you there are 30, right, or more. I mean, that's just... So we wanted to figure out how can we leverage 30 engagement practices, okay, bring everything, almost everything that is known about treatment engagement to people who can use it. Our other design principle is we wanted to make it knowledge-centric. So we didn't want this system to be, or we didn't want what we built to be static. We wanted it to incorporate different information sources to make it useful to mental health clinicians. And we structured it within the context of a decision-making flow that begins with identifying a problem, identifying a problem, which is the thing that you always do when you're, a clinician. You're trying to figure out, what am I working on? Selecting a practice, implementing the practice, so actually doing something in therapy, and seeing how it worked. Okay, so we took this as our implicit model, but we made it explicit in a series of resources. And we did that because without an explicit decision-making model related to engagement, it's easy for people to cut corners or rely on their habits. So for problem identification, it won't surprise you, we used this MTT questionnaire. That was going to be how mental health providers identify what the engagement concern is when they're working with children and families. We took those 30 engagement practices and created a library of engagement modules derived from the literature. They are standalone modules, so they don't rely on knowing one or another to deliver. And they're extensible, meaning that we can build out this library as new discoveries are made in the literature. And we also created what we call a coordination framework. And this is just a worksheet that we made where it identifies the reach problems are on one side. The corresponding practices, remember I said certain practices are relevant to certain problems? It identifies these practices, and it tells people, it gives ideas, actually. It doesn't mandate anything, but it gives suggestions about what to do when, okay? So it structures a decision-making flow. So we have these 4 different resources embedded in this decision model, and in our own work, we actually trained mental health providers and supervisors to use these resources together, because talking about engagement challenges, as you can tell from my example, is useful, talking about it with somebody else. So we worked with 145 school mental health providers, or mental health professionals, 115 therapists, 30 providers. Stephanie, here's your slide now. We worked in Los Angeles, California, rural South Carolina. Why do we work in these 2 sites? They are super different. Los Angeles, if we're talking about size of school districts, number 2 in the country, Los Angeles Unified School District. very heavily resourced, high organizational capacity. The workforce is trained in many evidence-based treatments. The opposite is true in South Carolina. We are one of the last on almost every health indicator. We have very few resources for mental health services. So we randomly assign people to use the Reaching Families resources, or underneath is what we call practice guidelines, which is just a light version, just telling them what they could do, just the engagement practices. We screened children and families for engagement concerns. We let providers know when a child or family reported a concern, and we asked them to record 3 supervision sessions and 2 treatment sessions. We listened and transcribed their therapy and supervision sessions, and we were looking for these decisions and how they talked about engagement in their work. And what we found was that in the practice guidelines condition, they did use this decision model. But even though we had told them these youth had engagement concerns, they used the decision model not about engagement. They didn't talk about engagement or do anything related to engagement in their treatment sessions. They focused on the clinical problem at hand. In the other condition, they not only talked about engagement, they went through this entire decision-making flow. And not only that, it wasn't just that they were talking about engagement. The things that they talked about and did matched the reported problem that children and families told us on that MTT questionnaire. So they were able to strategically discuss and act related to the concerns that were most important to the children and families in the project. We found that there were no differences across the 2 sites, which is astounding because of how different these places are. I'm going to wrap up in 1 minute. It didn't require more time or anything like that. I'm happy to talk about that later. Wrapping up, because I've gotten the 1 minute, I'm going to bring it back to Reach. Thank you for your attendance today. You did the basics. Thank you. I'm not done, though, because that's relying on attendance. I hope my intention was to bring clarity about engagement and expand what you know about engagement. I hope that I shared a little bit about myself in a way that maybe you found interesting or funny. You might find me credible, but know that I'm an ally in trying to help children and families. I'm going to come back to expectancy. I'm going to double down on this one. We can achieve a world in which all of these things are true because treatment engagement, by making adjustments, we can improve the lives of many of the children and families that we work with. If 50% are reporting concerns, making small adjustments can dramatically change the ways we work with children and families. And so what actions can you take? For the sake of time, I'm not going to read these, but if you're attending my workshop, that's already one action. But I want you to think about what can you commit to doing that is different the next time you go to work, than is different from how you're acting today. And so goal setting and eliciting a commitment, those are 2 of the foundational skills in homework, okay? Thank you for your attention today. Okay. Stephanie has a question?
Actually,
I met Stephanie 5 minutes before I gave my talk.
So, Stephanie with Discovery Behavioral Health. I just want to say this. Yes, it's almost as if we're doing ACT right now, acceptance and commitment therapy, where we're accepting that, yes, it's over 50% in Miami-Dade, in Broward, I would say the Tri-County area, that's needing a lot of resources. So just by being here today, that, everyone is committing to take that first step. But I love what you said, that we're in 2 different locations doing the same thing. Nothing's different. It's just the resources, the limited of resources. Mm-hmm. So I just want to congratulate you on this speech. I'm sorry I wasn't here at the time. But I wanted
You're very sweet.
I really enjoyed it, and I really appreciate what you're doing in South Carolina. And here in South Florida, we have so many resources, but we don't have the accessibility for them. So this is why you're here, and thank you.
Thanks, Stephanie. There's okay.
Thank you for your presentation. My question and comment is, we talk about how engagement is dynamic, but also the clients that we serve are dynamic in a sense that they change, and sometimes what we get one week is not what we get to the next week. How do you factor that in looking at engagement?
Oh, I love this question. So, yes, it's exactly what we're talking about, that people can seem engaged, but maybe they have an outside crisis and whatnot. And so in our work, what we've been doing, as I said, we give out that My Thoughts About Therapy questionnaire early in treatment, about two or 3 weeks in, to get an understanding of where are people at this point in time. And then we identify if there are concerns, we pay attention to those concerns, and we continue to give the subscale that, because it's short enough to give it on a regular basis. But even outside of a questionnaire, you can ask questions about somebody's treatment engagement or their life experience. What is making it, what are you going through today that might change the way that we interact today? We're actually going to talk about this more in the workshop I'm going to as well. But thank you for bringing it up, because it is such an important point that people are dynamic as well, including ourselves too. And so being mindful of that in therapy is important to engagement.
Please join me in thanking
All right.
Dr. Becker.
Thank you. Thank you.